Hi, everyone. Welcome to the SAEM Trauma Interest Group online lecture titled Contrast Enhanced Ultrasound in Trauma. It is my pleasure to introduce to you Dr. Joshua Davis. Dr. Joshua Davis is an emergency medicine physician in Wichita, Kansas, who teaches as a clinical instructor at University of Kansas School of Medicine. He completed his residency at Penn State Milton S. Hershey Medical School, completed medical school at Thomas Jefferson University, and received his undergraduate degree from the University of Delaware. His research interests are broad and include emergency medicine clinical topics, along with patient safety, handoff communication, and diet and exercise. He has published over 50 peer-reviewed articles, given multiple national presentations, and written several books. Dr. Davis, I will now turn it over to you.
Thanks so much, John. I really appreciate it. So today for our trauma interest group presentation, we're going to be talking about contrast enhanced ultrasound in trauma. This is a relatively short lecture, just to kind of overview of the topic so that those of us who haven't been exposed to it will be able to understand a little bit about where it comes from. I, of course, don't have any lecture or disclosures to give regarding this lecture. So by way of introduction, I think we all know the value of point of care ultrasound in trauma, namely the FAST exam or EFAST exam, to be used for hemodynamically unstable patients, highly sensitive for detection of free fluid, rapid, available at the bedside, expedites the patient to go to the operating room for definitive care without any delays of needing to go to CT. Secondarily, there's the benefits of lack of radiation and cost, which we find with a lot of our ultrasound imaging that helps. However, there are some limitations, namely that the FAST exam only identifies free fluid and not injury location per se, which could help with operative planning, and also does miss lesions that aren't developing large amounts of free fluid, at least immediately. It does have some benefits though. Ultrasound was really helpful in pregnancy and children, where you want to try and avoid the radiation. But due to those limitations of the non-contrast enhanced exam, we have developed some contrast agents that have been started to be used for contrast enhanced ultrasound in trauma. These are a couple of the brand names. Typically they're microbubbles and they have some sort of phospholipid shell around them that allows them to be seen readily on ultrasound. Definity is probably the most common one that you see, and where you've seen Definity is it's actually used for echocardiograms to look at the left ventricle and improve visualization of the left ventricle. The third one down, Optison, is also another agent that is often used for echo. And then the Lumason and the SonoView are approved for visualizing liver lesions, and in pediatrics for vesicoureteral reflux. So that's actually more of the one that you'd be more likely to see in the traumatic setting, because it's been FDA approved for at least some form of tissue that we are typically looking at, whereas looking at the left ventricle is not something that we typically do. Lumason is made out of sulfur hexachloride, whereas Definity is made out of perflutin. What the difference of those is, I think, is probably irrelevant. The last two, Levavist and Sonazoid, are ones that you may hear of in the future. They are not currently in the United States, but they are approved in several other countries throughout the world. And these contrast agents allow you to visualize lesions, particularly in trauma, parenchymal injury. There are other lesions, again, that Lumason's approved to look for, to look at hepatic cysts and hemangiomas and those type liver lesions, but it's been used off-label to look at parenchymal injury, particularly in the liver, the spleen, and the kidney. So it's important to recognize that there's only 3 FDA-approved ultrasound contrast agents. Those other 2 are not yet approved in the United States, and none are approved for trauma per se. And the other 2, the Optison and the Definity, are actually echo agents, and I don't think anybody that I'm aware of is trying to even use those for trauma. And I don't know about you, but all the cool kids in Europe have been studying this for like 10 years now, this contrast-induced enhanced ultrasound for trauma. And I get all of my fashion trends from Europe. So these are some of the fashion trends that I've tried in the past couple of years from Europe. I think I would look pretty good in some of those. So moving on. So why would I want to do contrast enhanced ultrasound? It's something new. I don't like using new stuff. It's technology. What are kind of the benefits of using contrast enhanced ultrasound? Well, the first major benefit is it kind of can avoid. So it can have some cost savings, so avoid money. It also avoids some of the issues with brain deposition of MRI, nephrogenic systemic fibrosis, contrast-induced nephropathy, if you still believe in that. That's a whole nother lecture to go into. It can also aid in patients who have true allergies to contrast dye and not those iodine allergies that we hear about a lot. And then contrast enhanced ultrasound also has all of the benefits of ultrasound. So it's low cost, it's rapid and can be done at the bedside. There is no ionizing radiation. And it can be relatively accurate for specific lesions, as we'll get to in a second. But the next question, rather than how to do it or why to do it, is kind of comes to the question of how do you do it? So the practical aspect of getting the contrast enhanced ultrasound, the first thing is you need an IV. You need a large IV proximal to the antecubital fossa. And the reason for that is because you're going to be taking the images and they can be metabolized relatively rapidly. And so you want all of the contrast to go in one bolus. You don't want it to kind of trickle in through the 24 gauge in the patient's thumb, where you're getting one bubble at a time over 10 minutes. The next thing that you'll need besides an IV, you'll need a machine that has a setting that is able to view contrast enhanced ultrasound. Many of the newer machines have these available. It's a low mechanical index setting. The high mechanical index will kind of disrupt the bubbles and destroy them so that you're not able to see them as well. So most of the newer machines will have this as an option. Not all of them, but your 1999 Micromax with one probe that's in the trauma bay that has a handle that's broken and 3 keys that don't work is probably not going to be the machine that's going to have the contrast enhanced ultrasound setting available that's going to help you. The other thing is that you're going to need some time. So these are very long clips that are taken. So you're going to do 3 different phases, just like they talk about in CAT scanning with contrast. There's going to be an arterial phase, a venous phase, and then kind of possibly a washout phase, not necessarily relevant to trauma, but you're going to want to change your clip settings from 6 seconds, which is what most of us have them set on now, to like a minute. And then depending on what organ you're looking at, it can be anywhere from 1 to 2 to 3 minutes to get to that arterial and then venous phase. And then the washout phase is typically 4 to 6 minutes after, 4 to 6 minutes total in, you'll start to see the washout phase. So we'll take a look at a couple clips here. So this clip here, you're seeing a liver lesion. In the top left corner, the box A, you're seeing it on a routine V-mode ultrasound. In box B, you're seeing it with the contrast enhancement, and you can see a much clearer liver laceration that's showing up there. Super clear on that contrast enhanced ultrasound. May be present on that B-mode ultrasound, but also could easily be missed in the setting of doing a rapid kind of fast exam in the trauma bay. And then you see the corresponding CT images, so you can see what you're actually looking at is actually present and is actually a liver laceration there. And then another lesion here, another liver lesion. This one's hidden even more on the B-mode ultrasound. And then you can see both the arterial and the venous phase here in boxes B and C. So the arterial phase in B will show you the liver laceration. And then in C, you actually see some of the ultrasound contrast extravasating, telling you that that is an actively bleeding lesion. And then when you go down and you give the CT contrast and you look there, it corresponds and shows you that it is actually an actively extravasating liver lesion that probably needs an operative intervention. So that could obviously be very helpful in rapidly identifying these lesions. What you can see with contrast enhanced ultrasound is the spleen, the liver, and the kidneys relatively well. What you cannot see, diaphragmatic injury, which, I mean, even CT can miss diaphragmatic injury. Intestinal injury, also CT can miss that as well. But the stomach and the pancreas are things that you're not going to be able to see very well on the contrast enhanced ultrasound. Just mainly, retroperitoneal structures are also difficult especially considering the pancreas is mostly retroperitoneal, but really anything in the retroperitoneum is going to be difficult to see on contrast enhanced ultrasound because you can't really visualize that very well. There's some question about whether bladder injuries can be seen well with contrast enhanced ultrasound. So when they use it for vesicoureteral reflux, they actually do like intravesicular boluses of contrast. So if we're going to do intravenous contrast, it's not clear that that's actually going to visualize bladder lesions, but some are investigating that. And then regarding kidney lesions, you will clearly see parenchymal kidney lesions, but the collecting system isn't always visualized as well because, as you know, the contrast agents are actually don't make it necessarily all the way through the nephron and get filtered out before it gets into the collecting system. So it's difficult, not impossible, but very difficult to see collecting system injuries. So that being said, those are some of the limitations of the contrast enhanced ultrasound is that you can miss some lesions. So if you have a high suspicion for them, you probably need to do a CAT scan anyway. It's operator dependent and needs some training and experience, just like all ultrasound. I think, you know, some of us had a learning curve to learn the FAST exam. And so adding this into your arsenal will take a little bit of training and experience. In the setting of a trauma bay, it's also going to be a little bit more timely. It takes a little bit longer time than your FAST exam. And so you really need to have a whole team that's on board with this. And I don't know how your experience has been and how you run trauma at your shops, but in my shop, the trauma surgeons are very much like, we debate about whether patients need pan CT scans or not. So I think introducing this contrast enhanced ultrasound to would have to be on a systemic level to your trauma team. And we would have to have instances where it's going to be indicated. And then there's the technology curve as well. So you have to have an appropriate machine. You have to have the contrast easily available in the trauma bay. We're not going to be waiting to kind of do this for an hour to get it from pharmacy or wherever else you may store it. So the benefits being, though, you know, you would have some benefits maybe in pregnancy where you want to avoid radiation, in children where you want to avoid radiation. And then, as I said, in those lower risk mechanisms, you may be able to avoid doing the CT if you have a low suspicion for a serious injury. So when would you use it? Not really ready for prime time in the United States yet. Definitely on a research plan at this point to correspond to kind of either clinical course or CT findings. But that being said, it has been well done in Europe before, and they still do use it in Europe for many of their traumatic evaluations. So pregnancy, children, as I talked about, low risk mechanism, and then your, you know, quote, iodine allergies might be an instance where you're able to get at least some imaging if you have some pushback or something from that, or from contrast-induced nephropathy, if that's also a thing that is still a worry at the site that you shop, at your shop, at the site that you work at. So in discussion or in conclusion, you know, all the cool kids are doing it in Europe, at least. It's ideal to be studied in selected populations and mechanisms. Like I said, I don't think that this is for the MVC with rollover and ejection and 3 other passengers died at the scene. Like, I don't think that this is the right place to use for that. Not to be used for pancreatic, retroperitoneal, or intestinal injuries. So if those are what you're suspecting, you're going to go ahead and need a CT. And when you're introducing this, it has to be something from a team approach. So whoever's involved in trauma at your site has to be on board that this is going to be something that you're going to start introducing or at least studying when it gets to that point. I think at this point in the US, we're still talking about studying and not necessarily introducing it into the clinical setting quite yet. There are some sites that are studying it. I'm aware of some on the West Coast. I don't know of any on the East Coast, but I assume there are probably some as well that are starting to look at this, and Canadian sites as well. So it's definitely something that will be coming and you will be hearing about. So it's just something that I wanted you to be familiar with and understand a little bit about. So that's it. That's all we got today. So if you have any questions, comments, concerns, opinions, anecdotes, monologues, diatribes, or feedback, most importantly, you can reach me at jjdavis@vituity.com. Thanks again for joining.
Okay, thank you, Dr. Davis, for this very informative presentation. And thank you to everyone watching this presentation for the SAEM Trauma Interest Group. Have a good day.